This is why mental health is so complicated, guys. Like, not only is there the incredible complexity of the individual in front of you, but there's also the complexity of the kind of commercial and social factors influencing how humans understand disease and wellness. So, really hard field. But hey, I'm here now. Well, hello and a warm welcome to this comments and answer video. This was a really cool video. We talked a bit about kind of normal beliefs, conspiratorial thinking, delusional thinking, overvalued ideas, obsessions, how they all relate. We talked about advice for people with lived experience going into the mental health field. We also talked a bit about what is the best psychotherapy, what is the best base psychotherapy to kind of train, and then the other types of psychotherapy. We spoke a bit about hypnopompic hallucinations, what to do if your parents won't get you psychological support, and which mental illness is the most difficult to treat. So if that sounds interesting to you, then please stick around to the end, like the video, subscribe, and leave your comments down below so that I can answer them in the next video. All right, let's get into it. Let's get some lemon and ginger in. And away we go. Okay, Hetty Wallace, 7601. Hi, Dr. Syl. Love your videos. Thank you for making them. You're welcome. Question. The way you speak in videos is often quite gentle and calm. Is that something you've developed from working with patients in distress? I'm wondering if you keep your voice very calm, it helps others regulate themselves to meet you. If that makes sense. Have a lovely day. Thanks for the question, Hetty. So I think it's an interesting question because I have and am still kind of trying to, I guess, develop my voice. I don't know if it's the voice specifically I'm working on or more like trying to find the right tone, because it's kind of hard for me. I'm an optimistic, jovial, bright kind of person by nature, but I'm dealing with content that can be extremely dark and people who are in deep distress. And actually doing the workout videos where I was kind of doing workouts and then answering questions about suicidal ideation felt like completely jarring, which was one of the reasons I changed back to this kind of format. And of course, the great feedback I received from everyone. And so finding the tone has been a bit of a journey. I think that calm. When a child is developing, their nervous system is a mess, and they have to basically borrow their parents' nervous system. So a child isn't able to regulate their emotions. So how do they regulate it? They model based on the parental response. So in our nature is this capacity to model the other's emotional state. And it's really important in mental health to be well regulated. And that can be very hard if you've got your own background and or if you've slept poorly, or if you're not in a good headspace. So I do see psychiatry as a performance sport, funnily enough. Actually, I would say more like a performance art. And it's very much about being in a good place yourself so that you can help others. And definitely, like, if someone is screaming at me and very dysregulated, I'll remain as calm as I can. And that's a key part of verbal de-escalation. There was a term I heard the other day that was an interesting one, something about like infectious calm. And it's about like a parent-child dynamic where the child was getting anxious and the parent was getting anxious, and then the cycle just gets worse and worse and worse. And how actually it's really important to kind of contain it and just be present with it, and then watch the kind of anxiety dissipate through the relationship, because the relationship itself can heal. So that was an interesting expression that's relevant to this question. Thanks for wishing me a good day. It's a great start to the day. Yeah, I wake up early, so it's 5:50 a.m. on a Saturday morning right now. So I don't know if that's what people normally do with their Saturday mornings, but I like it. I kind of do this stuff in the morning, and then I go do my shopping, do my cooking, get all my chores for the weekend done, and then I can just relax and hang out with friends and chill. Here's another comment about my voice. It looks like we have a theme today. I feel like because of these comments, I'm putting extra effort in making my voice sound calm. All right, would you consider making a meditation video? So RM, I actually have a couple of, I think 2 meditation videos. They're just not like well known, but if you type in Dr. Syl meditation, I hope they'll come up. Why don't we try that out? Let's see what comes up if we go youtube.com and then type in Dr. Syl meditation. Yeah, there you go. I've got a non-sleep deep rest and a progressive muscular relaxation one. I filmed them a while ago, so if they're crap, let me know. But I've got an okay feedback in the comment section. People said it was nice, so hopefully that works for you. Continuing the comment, your voice is really calming and pleasant. Another question is, how do I know whether the amount of help for a family member who has mental illness becomes too much? So, doing something for them that they better should do themselves or not. I'm afraid sometimes that I unwillingly support the mental illness by helping them too much with daily life tasks or doing them for them. The person can't see that she is ill and isn't willing to go to a doctor, but struggles a lot. Thank you. So that is an incredibly difficult situation and a very nuanced case-by-case answer. When does being helpful become being harassment? When does being helpful become harassment? So, like, it is actually quite a fine line after a while. And I've worked in a bunch of community teams where you manage voluntary community clients that might disengage with the service. And how hard should you try to keep them with the service? And it depends, like what their baseline mental health is like, how they're going at the moment, what their mental state is, what the risks are. All these things inform the level of assertiveness you might need. If you're in this family dynamic, it's so hard. I guess you've got someone who, according to you, doesn't have insight into their needs, and it sounds like you're compensating for their lack of something, their lack of initiative, their lack of doing things. That you're doing something for them that they're not doing for themselves. Well, it's too nuanced for me to provide a generalist answer, but what I would say is that if you do less for them, and they kind of hit rock bottom and things aren't going well, that might give them the insight that they need further help, that something's up. But what does tend to happen is that family compensates for an individual's deficits, and so things just keep going, and you get burnout, and you get carer burnout particularly, and then eventually things will crumble when the carer has other priorities that come up. You see this a lot in older person's mental health, where like when one partner in the couple passes away, within a couple of weeks the other person deteriorates, but it was because the other partner was compensating for their kind of deficits. Sorry, I can't think of a better word, but for what they weren't able to do. It's really sad. So because I guess I'm not in the dynamic, I tend to feel like you should try to do less so that the person can generate some insight and then just gently encourage them. But I recognize that I'm not in the dynamic, and it's easy to say that from the sidelines. And the ultimate goal is, if it's serious enough, to have a good support team involved. I mean, anyone with poor insight, and if someone's having a mental illness with poor insight, it's just going to be challenging, right? Because if you don't want help, what can you do? And in mental health, basically it's the risks. I mean, there's different factors we look at when thinking about involuntary treatment, but it's basically risk. So is there going to be harm to the self, others? Is there going to be further deterioration? It's going to be refusal. So are they refusing treatment that could improve the risks? And insight's a factor as well. Do they understand that they have a mental illness and capacity? So are they able to recognize basically the risks and benefits of the different decisions they could make? And if those things are met, then you can sometimes justify the use of involuntary treatment. All right, next question, J.K. Hawkins. Thanks for the video. I'm enjoying the Q&A format. Thank you. I'm enjoying doing them. It's actually like such a good format because I don't need to do, like, it's just very low workload, so I could integrate it in my daily routine really easily. It's minimal editing. You guys are doing all the hard work by finding the content, and I can just kind of click on for the whole studio to turn on and then answer questions and then click off, and it takes me half an hour to edit it. So the question is, how do you tell the difference between unusual beliefs, conspiracy theory beliefs, and delusions? Is there a particular technique? Ooh, that's a good question. So for this question, I think we need to think about the spectrum of belief, right? Where do beliefs land in terms of kind of hierarchy? And in psychiatry, I guess we can think of three kind of levels, or maybe four, I guess. There's just kind of ordinary beliefs, then there's overvalued ideas, then there's obsessions, and then there's delusions. And that's the kind of, that order represents the increasing severity of the conviction of the belief. So let's talk about the two extremes and then kind of go towards the middle, which is where things kind of get a bit more tricky to disentangle. I guess an ordinary belief is something that typically can be changed if evidence is convincing and ranges in the conviction. So I might have the belief that I don't know why this is coming to my mind, but what comes to my mind is that when water freezes to ice, that it expands in volume, right? And I have a pretty high conviction of that belief because I've seen drink bottles expand, and I did chemistry and remember that the hydrogen bonds in a fixed rigid structure of solid state adds distance between them, and so it needs more volume. But if a professor, if a Nobel Prize laureate in chemistry came and sat with me and started explaining to me that actually it's not the case and that there's other reasons to explain my observations, I might change my belief, right? Weird example, sorry, but that's the point. That's a typical belief. All right, now let's go one step up. The next step up is overvalued ideas. An overvalued idea tends to be based in reality, so based on your observations or your experiences, and is held with conviction, but is kind of disproportionate to what others would consider normal or what others believe, and the person recognizes that other people don't have those beliefs. So think of someone with anorexia nervosa who thinks they're overweight, they realize other people would call them skinny. They realize that on the BMI charts they're underweight, but they have this overvalued idea that they're actually overweight. And it's pretty dominating. It's taking over a lot of their thinking in their day, but they can do other things. And I guess in this area between normal and overvalued idea is where a lot of conspiracy thinking might occur. So for the general population, so especially if someone's got a paranoid personality or distrust in the government, most beliefs would be landing in this area. And this isn't necessarily an area where you need active intervention. I mean, people can just have overvalued ideas and live their life fine. And typically these overvalued ideas are egosyntonic, which is a term we use when the actual belief is aligned with what the person wants to believe and how the person sees themselves. And that's important because it differentiates it from, for example, an obsession, which is often ego dystonic, which we'll talk about now. So the next level up from overvalued idea is obsessions. Obsessions are intrusive, right? The person does not choose to have these thoughts. They kind of intrude into their life, and they're often ego dystonic. They are ego dystonic, and that means they're not pleasant. So a person who has fear of contamination, that their hands are dirty right after washing them washing them 2 times, and then they feel their hands are dirty again, so they have to wash again. They don't want to wash their hands again. They didn't want to, it's against their values. It's against their sense of self and what they want in the day. But they're spending hours washing their hands, right? So that's ego dystonic. And it's obsessional because, first of all, it's intrusive and dominating. So, if someone's missing work, not able to leave the house, not able to go on a date because of all these kind of intrusive fears, that's obsessive power, right? That's very powerful. And then if there's a compulsion, such as washing hands or doing some kind of ritual, that's pretty typical in an OCD. And then the next level up from obsessions is delusions. So that's a fixed and false belief held with extraordinary conviction, and very hard to get any kind of nuance or like doubt in the belief. There's lots of different kinds of delusions as well. Erotomanic, persecutory, paranoid, grandiose. So beliefs are a complicated thing. To be honest, it's actually pretty tricky sometimes to differentiate what is a delusion versus an overvalued idea versus an obsession. And you can get OCD and schizophrenia overlapping, and that's kind of so-called schizo-obsessive presentation, and it can be a tricky thing. All right, Camo222. Next question is, what advice would you give or might want to give to someone just starting up school but would like to go into the psychiatry field, especially someone who has lived experience dealing with and managing a serious and persistent mental illness? Love your videos, so insightful, informative. Thanks for the kind words, Camo. Look, what I want to say is that anyone can work in mental health field, and I do think that's true. I guess, the typical. I guess I just don't want to beat around the bush that there's no trigger warnings in mental health, right? There's really good support. There's really good, managers who understand that a lot of the workforce have lived experience, but you want to make sure that your own mental state is optimized, which might mean, seeing a mental health professional and seeing if anything needs to be done. But what it definitely means is that whilst working, you have a good support network, so that if things get destabilized, that you have kind of people you can go to and a manager that knows how to best support you, because, you don't get to choose what other people say. And I want to say that it's a happy-go-lucky, everything's going to be fine and dandy, but the reality of the situation is there's some really difficult shifts that you will get exposed to, very tricky situations that'll bring up a lot. And I can't say it's a good or bad idea. I think it's I think it's been wonderful. I know many people with lived experience who work very successfully in mental health. And it seems to work really well if people go part-time, and so they have time off to kind of recover. So, I guess just think outside the box and make it work for you. But you absolutely can have a really meaningful career, even if you have lived experience. All right, a couple more comments. So next question. Excuse me, I got to stay hydrated. All right, thanks for answering my question, Dr. Syl. Oh, nice, we got some repeat questioners. If you need another one, sure. I was also wondering what theoretical orientations you would recommend as being particularly useful for psychotherapy, maybe for me to consider as my base theory within an integrative approach, and why. Thanks again. Wow, good question, Mohammed. Well, psychotherapy. I like psychodynamics the most as an approach of understanding the mind. So like reading about, like following Nancy McWilliams' psychoanalytic diagnoses felt like the best approach to trying to understand personality structure. But the evidence is pretty messy because actually, oh my gosh, my stack of papers off screen. Yeah, look at that. This is a paper called The Efficacy of Psychodynamic Psychotherapy. This is a Shedler paper, and it's kind of a big paper in the psychodynamic field where he, in that paper, he's talking about the significant effect size in a lot of studies of psychodynamics. That paper has some, criticisms. Well, it has some flaws. I mean, it's not a systematic review, and it doesn't talk about statistical significance at all, just global impact. So I guess what I took away from reading the literature from my read of the literature in psychotherapy is that it's very hard to disentangle one therapy from another. And often therapists, from my experience, do a bit of everything. So, for example, you might say you're doing CBT, but a part of CBT is kind of metacognition and recognizing your own thoughts and trying to get insight into, what's unhelpful, which is also quite a psychodynamic principle as well. So what's one and what's the other? And a lot of CBT involves psychodynamics. A lot of psychodynamics uses CBT principles if I guess it's less structured, but there might be situations where you do try to kind of work together to have some behavioral activation and challenging thoughts that you might see in CBT. So it's just a little messy to be very sure about one thing or the other. I would say that, I don't know if you're doing psychiatry or therapy particularly, but it's really at the end of the day, it's the relationship that heals. It's the therapist and the rapport with the therapist that seems to be the strongest predictor of good long-term outcomes. And so if you have a crappy therapist doing CBT and a great therapist doing psychodynamics, I should reword that. If a patient finds that there's a really good therapist for them doing one model over another, then that's what they should stick with, because it's the relationship's the most important kind of predictor of good outcomes. So I don't really have a good answer to you. There's so many therapies, and a lot of these third wave therapies that seem good as well, like mentalization, schema, and EMDR and stuff. So I'm sorry I don't have a good outcome, a good response, but I would definitely try and be psychodynamically informed in whatever you do. So that for me would be my base, and then the therapies used would be the kind of tools, but the psychodynamic base would help with your formulations. Yeah, that's how I would think about it. Good question. Sorry, I don't have a good answer. Okay, Huntress Wizard. All right, thanks for answering. So if I meditate regularly, I sometimes hallucinate in the morning right after I wake up. It never happens when I don't meditate and only lasts a few seconds or a minute. Should I be worried about that? I am aware that what I see is not real most of the time. And my name's from Adventure Time, by the way. Huntress Wizard. That's a hypnopompic hallucination, and in and of itself is not particularly worrying, but I don't know anything about you. So you've got to talk to your doctor. I wouldn't be running to the emergency department if the only symptom you're experiencing is hypnopompic hallucinations, personally. But yeah, I'm sorry, I can't make a comment because we have to do full psychiatric assessments before we can provide personalized advice. Just bring it up in your next medical review. It's probably a good idea. All right, GR Gaming, I4D. I think we've got 3 more questions, and we're doing well on time. This is a longer one, though. That's good. I think I'm getting more and more questions, which is good. Yeah, let's keep going. What do I need if my parents don't believe or understand what I'm saying and also don't want to pay for a psychologist, so we end up running in circles, not understanding? Yes, well, I liked this question because it's really, really common that I'm assuming you're a kind of teenager or, 10 to 18, living at home, not seeing eye to eye with parents. really, really common, and you're wanting a psychologist, but they're not able to financially afford it or support it, whatever the reason. I guess I wanted this question because it depends where you are in the world, but in Australia, there are a lot of free services for young people. And you just got to look up in your country what they are. So just Google teenage counselling services and see what's around. In Australia, there's Children's Helpline, there's Headspace, Fearless Women is a counselling service for young women. The list goes on. So keep you can get support without parental. You don't need your parents' permission, and you don't need to pay, depending on where you are in the world. So please look up for other supports. All right, Grandmama Lama. These names are great. Always very interesting. Which psychiatric illness is the most difficult to treat? Which psychiatric illness has the worst prognosis? Oh, I don't know. I think most difficult to treat really depends. Some people with a particular diagnosis will have very easy to treat illness. Others will have a really treatment resistant illness. It's really, I think it's really challenging for everyone when someone's got an eating disorder and personality disorder. So an anorexia nervosa with borderline personality disorder is really difficult for everyone, for the patient, for the treating team. And it's also extremely high lethality. 10% of people with an eating disorder will, like anorexia nervosa, will die from complications associated with it. And if there's a borderline personality disorder, there's a high risk of misadventure, and those risks combined mean that it's a really important situation to try and improve, but also that it's going to be really hard because of multiple issues. So that can be really challenging and can bring up a lot. But I don't kind of want to comment on which psychiatric illness has the worst prognosis because it's so personal. It really depends on. I would say actually the illness isn't the most strongest predictor of prognosis. I would say it's kind of the psychosocial situation. So obviously, I think it's the formulation. So it's not just the diagnosis; it's also the social milieu of the person. So if someone's rural, low socioeconomics, severe illness, and difficult access to services, that's going to have a much worse prognosis than someone who's got good access to services, good family supports, good NDIS funding, a good psychologist. All that kind of stuff improves the prognosis. All right, last question. Silly Brain, such a good video. A side note, am I the only one who has serious beef with the DSM-5? Man, I hate it so much. No, look, you're not. The DSM-5 was widely criticized. The majority of diagnoses have very little to do with the kind of, cause of the illness or even attempt to explain it. I guess I'm bringing that up because they refused a diagnosis called developmental trauma disorder. Yeah, I think that's what it was called. And it was a disorder that I think would have been really helpful. It captured young people who had been exposed to trauma and have symptoms of interpersonal dysfunction, emotional dysregulation, and attention deficit issues. And so instead of getting a developmental trauma disorder, now we have all these young people with autism, ADHD, depression, anxiety, diagnoses, when it's kind of, that really messes up the picture and distracts from the core issue and leads to a lot of prescribing of medications. That may or may not help, right? I'm not saying anything about that, but it's just something that's a bit of a shame. And I guess the other thing to say about the DSM, it's really hard. I mean, I really admire the work that the people on the task force are doing, but let's also not kid ourselves that there's heavy ties to kind of commercial interests. There's a lot of conflict of interests amongst the authors, and the DSM-4 netted about $100 million of profit. So it's definitely a kind of, you just have to be very aware of the commercial biases and take that into account. This is why mental health is so complicated, guys. Like, not only is there the incredible complexity of the individual in front of you, but there's also the complexity of the kind of commercial and social factors influencing how humans understand disease and wellness. So really hard field, but hey, I'm here now. All right, guys, that was a lovely video. Thanks for all the comments, and I hope you enjoyed it. If you want to keep seeing them, all I ask is that you keep commenting, and I'll see you all in the next video. Okay, bye for now.